Hello, I'm Dr. Sarah Cole. I'm an orthopaedic surgeon based in Kent, father of Queensland. And this evening it is my great pleasure to introduce Ben Woods, who is going to talk to us about shoulder pain, but we're hoping to do a bit of a deep dive. Is that all right?
Deep dive into the athletic population?
We can do the athletic population as well, because that's your passion.
Perfect.
But we'll cover whatever you want to cover.
Beautiful. Sounds good. So just a quick little rundown of what we're going to go through. Basically, there is obviously a lot of causes of shoulder pain. We're going to stick with the more common ones though. So rotator cuff related shoulder pain, instability, biceps related pathology, shoulder stiffness, and scapular pathology. So just a quick little bit of a rundown. So obviously a very common disability in athletes and in the population altogether. Zoom in a bit.
Yeah, is that coming from here?
Yeah, I zoom in a bit.
Yeah,
yeah.
The image is bigger.
Yeah.
There
we go.
Okay, great.
Beautiful. Obviously predisposed to injury due to its large amount of mobility. Great for function and power, but also inherent instability and injury. So we deal with acute injuries, usually traumatic, where excessive force is placed on the shoulder, and overuse injuries. Mainly, that's what we're going to deal with in the athletic population mainly. So younger shoulders, traumatic, hypermobile, overuse. Obviously, rule out serious pathology as well. Imaging is quite helpful for that. Mature shoulders, more likely to be a rotator cuff related shoulder pain, OA as well, and AC pathology or frozen shoulder. So language is important when dealing with shoulder pains as well. So trying to de-threaten where possible. You want to promote movement, promote resilience in the body. You don't want to, get them more fearful with kinesiophobia and those type of things. Is that what you found sort of with your patients as well?
Yeah, I think it's easy to so you're in a position of authority when you're talking to the patient about their shoulder, and I think it's important to gauge their relationship with the shoulder as you try and articulate the urgency or not of the situation. And I think the talking about tears and patients get pretty distressed once they've identified that they've got a tear in their rotator cuff. And I have had patients who are pretty adamant that they want surgical fixation once they've identified that they've got a tear. And so I do, as you say, I do a bit of de-escalating.
Sure.
And the key statistic that's useful is the 60% of 60-year-olds have the rotator cuff tear on ultrasound. And that's a great number to use because you can, I think the message you're mostly trying to communicate is perhaps this is not acute. And patients really struggle with, but I've got an ultrasound that I've got a tear, and then you're trying to explain, well, I'm not 100%, how did you do it? Well, I don't remember how I did it. And I'm, so from a surgical perspective, when I get in there and look at the tear, there are definitely features that tell me how acute it is. So if it's got a ragged edge on either end, or there's a little stump left, where it tore from, then it's usually acute. But once it's been there for a while, the edge sort of curls over a bit, and the whole tendon becomes atrophic, which you can also see on the MRI thing. You can see that the tendon's kind of curled and retracted away, and so the retraction is kind of a nice thing on the ultrasound to sort of flag. Either it's gone bang because it was such a big tear, or it's actually been retracting for a while. So I use that. That's a useful word in the ultrasound to sort of say, do you think this could be old? Yeah, so that's how I do a lot of de-escalation. And also instability, I'm sure you're the same. You can have a little bit of labral instability and you can work with that. So you do an MRI scan that shows a labral tear, it doesn't actually mean that you've got to race it and operate. I'm sure you do the same.
Yeah, definitely.
A lot of education around what you want to do with a labral tear that doesn't require surgery.
Yeah, we don't have the ability to go in there, so we use de-escalation.
So do I. So I'm an operator who's not ready for a procedure, and so that's where I think you have to work together. And be on the same page.
For sure. No. So site of pain, I think we were pretty in agreement on this one. The AC joint and bicipital pain is generally pretty localized, but other than that, it is quite hard to identify which structure is causing the pain. Sort of can refer up into the neck, thoracic spine, or down the arm, rarely above the elbow, do you find? Or unless there's radicular pain involved or a nerve impinged or something like that.
So if I'm worried about radicular pain, so that neck pain, I'm looking for paresthesia. So I always ask about paresthesia, and I don't know about you, but with instability, I quite frequently see a bit of paresthesia. So I don't always kind of, oh my goodness, it must be neck because I've seen because they've got paresthesia in their fingers. If it's proper shoulder, it tends to be biceps, it tends to be lateral neck because they're hitching, or scapular. As opposed to radicular, which it has a different nature.
I agree. And I would say I've never really seen a true rotator cuff tendon referred down past the elbow.
What I see there is their tennis elbow comes
for sure.
So it's a burning tennis elbow-y kind of pain.
Definitely, for sure. So rotator cuff related shoulder pain with or without calcification and a partial or full thickness head. A lot of bench pressers, crossfitters, like we said, talked about, get this. Generally, you're obviously taking a detailed history. You're talking about sort of when it comes on, usually due to either an increased load in training, whether that's spamming the bench press or spamming the overhead press, or usually it's some sort of pressing exercise, even pull-ups as well. Lats being an internal rotator can sort of impinge or irritate the tendons if there's overuse there. You're mainly checking for lower trapezius weakness and external rotation weakness as a contributing factor. But the main thing is getting them to back off. Trying, it's hard to get them to back off initially, especially when they're training for competition or something specific. It's
I try and say don't stop, modify.
So
I try and say you don't have to stop, it's okay, you don't have to stop, we're just gonna do it. And that's why I like to send them to you to just say, I don't know what they need to modify. What do they need to do more of? And so what I'm hearing from you is they get a bit strong in external rotation.
A bit of weakness. So too much internal rotation, too much pressing. Forward. So pec, major, lats, subscat. And they get that sort of tendon irritation. Could be an overuse thing as well. It might not be the mechanics. Could just be a tendon overuse thing. But those are generally what the key features are for that sort of population. When would you surgically intervene?
So you mean generally speaking in rotator cuff related shoulder pain? So we were talking a little bit about impingement before. So the theory is that there's a sequence from impingement whereby they lift their arm up and that irritates their rotator cuff and they get pain. And then they get, in theory, they go on to getting a partial tear. And then the next theory is that it sort of unzips into a full tear. But there's a few nuances in there in that, certainly I think for the biceps tendon, there's a lot of biceps subluxation, which is just agonizing. And they reach forward and they kind of twist and they just, it dropped. Their biceps tendon sublux out of that groove and then they're in big trouble. And then they start getting that anterior supraspinatus tear at the front, and then it starts unzipping. So there's definitely a biceps tendon. But if you can get the history, sometimes you get that biceps tendon first.
Definitely.
And so I'm listening out as you're saying, listening out. Have they just got impingement? Well, impingement can wait. Impingement is a process. This is where you get those ultrasounds that say bursitis. So that's pretty frequent, and I understand, and they're great. You give them a steroid injection, you settle down the bursitis, and sometimes you're away, you have a big win. But when I look at the ultrasound, and I know you don't look at the ultrasound very much, if there's a great big thick rotator cuff tendon, like if it's a juicy, I tell the patient it looks thick and juicy like a big steak, they've got a great big tendon up there. That's not their problem. It's not rotator cuff pathology. If they've got a really nice, solid looking, something else is going on and missed it. So it's time to start looking at the neck, looking at stability, looking at, the physio's got to get a bit more nuanced about what they want to do. I was just going to talk about calcification. Calcification can be a different story altogether. Calcification can certainly be an incidental finding.
Really painful sometimes.
But it can be agonisingly painful. Like sit over the edge of the bed, 3 days of just the worst pain of their life. They think they're having a heart attack. If it's on the left side and they come in and they're crying, any age, they're just very distressed. I do what's called a barbotage, which is when that's good. When decompress it. So I just it's a little pocket of calcium, and I just repeatedly jab it with a needle. And the patient's very, very happy. So it's a little bit uncomfortable when I first start, but the patient's just like, no, keep going. So it just decompresses it. And all I'm doing is sort of perforating it, and the calcium's allowed to sort of leach out into the bursa, and it just takes that tightness out of that little deposit. And so that's all I wanted to say about calcification. But I see it all the time. It doesn't always have to be decompressed. So only if they're, like you say, in terrible pain, whereby you can't get near them.
Yeah.
You know that.
It's really hard to treat like conservatively because like that technique sounds quite like helpful.
That's the only surgical option that's really good. But you're right. It's a patient you can't even touch them. I would imagine.
Yeah, generally rotator cuffs, like when you work them a bit, they tend to get a little bit better. With those, and especially bursts, they get worse if you move them too much. Kind of thing. So you need to get them to like modify their activities and try and build them up like really slowly. Get them to basically not have any aggravating factors like
one back to nothing and then build up.
Pretty much.
Good.
Yeah.
I like that.
So obviously special tests, not so special. The most special thing is it's hard to remember. So screening the cervical spine as well. But they do have their place on a case-to-case basis, special tests.
But you know the beer can test, isn't that? Is that the one that GPs always know the empty can test? There you go.
Yeah. Well,
I think that tests supraspinatus.
Yeah, so I mean, technically they can rule in. Painful fuck is actually a good one. It's one of the better ones to rule in a tear or a tendinopathy. Sorry.
Right. It's a better predictor.
Yeah, better predictor.
Okay.
So
what about the empty can test? What are we testing there?
So empty can. So you get activation of the cuff like no matter
regardless.
Yes,
right.
basically,
okay. Great.
But full thickness tear of supraspinatus can be ruled in with an external rotation lag test. A full thickness tear of subscapularis can be identified with a belly press, ruled in.
Good.
For a plain tendinopathy or partial tear, painful arcs quite good.
Best.
Ruling out a full thickness tear of the aforementioned muscles is the Hawkins Kennedy. Yeah.
Really?
Yeah.
Which is sort of your empty can.
Yeah. So back and forth.
Yeah, there's so many different.
Yeah.
And to me that was biceps. That Hawkins. No, it's speeds. Go on.
And Hawkins Kennedy going across like that. Internal engagement.
What was that?
Hawkins Kennedy is going across.
It has been shown to actually be more specific for picking up infraspinatus and supraspinatus.
Infraspinatus than supraspinatus.
Yes. So they're not as a cluster set of tests. They've been shown to be very useful. But as a one-on-one, trying to identify a structure for the test, it's shown to be completely
different. Yeah.
But if you get a clear impingement, clear Hawkins, it's unlikely they have rotator cuff, which you can imagine.
Rotator cuff tear or rotator cuff tendinopathy?
Problem. If you pick nothing up, then you've got to be thinking
neck.
Really? So we screen that cluster of tests. And you get the guy that they come and do this, and you go, okay, can you do this? Yes, I can. Can I do this? Yeah, it's definitely rotator cuff. And they're going,
can't be.
The only exception we will find for that are the really high level athletes who are getting overuse of tennis. The tennis players, the swimmers, because they need a lot of repetition and a lot of weight to bring this
to demonstrate the tear.
Yeah, so they need because they're so strong in their calf to actually find that. You have to work harder.
Yeah, it's an endurance overuse thing.
Yeah. So you'll see then these really super strong gym guys.
Yes,
that those two are there with the kettlebells.
Demonstrate
and obviously they're going, I can lift things. But
and they can lift with a tear in situ.
Sometimes, but it's like when it's usually a tendinopathy more likely, right. You can usually tell with a tear because their range of motion's a little bit lacking, especially, and there's usually something traumatic, especially in the younger sort of population.
So what do they describe when you say traumatic? What do they describe?
So something that puts stress on the shoulder. So they might do like an overhead press and just feel it go.
Okay. Feel it give.
Yeah, feel it give. Yeah. So I feel or just like a searing pain kind of thing, and they'll have to drop the weight or something along those lines.
Got it.
Yeah.
Yeah, that's helpful.
Because
I think that happens a bit in work cover. You know, they're sort of going along in their day and they say, no, on this day I did something and it's just not been right since. And I think they don't necessarily remember the incident.
Definitely. Those tendinopathies are more like what I was talking about in the beginning, when it's like the overuse, kind of like loading it like quite a bit.
Yeah. Okay.
Should we move on?
Yeah. Yes.
For ultrasound, kind of, you know how they do the bombardment of the ultrasound waves for calcification.
To calcification.
Yeah.
I haven't found any like really strong evidence for that. Have you? No, I would say
for like Achilles.
Yeah, I know. They do
potentially work for the shoulder.
So like
Shockwave. Yeah. So shockwave therapy in the shoulder has been shown probably to be more painful than useful. So the whole idea of shockwave is you actually damage the tendon to get it to repair. So in the shoulder, that's hard. That can be a little bit simpler because of its design.
Yes.
Shockwave the shoulder tendon without using the burst off really badly is quite difficult. So just do that structure. Yeah, I mean, there's a lot of money in it. Well, I don't provide it. So that's nice ride machine. Yeah,
it's a ride machine. So that's a really good question because it did have a degree of popularity for a while there, and you know, I just don't feel like it's powerful enough to really break down the calcium deposits. But sometimes patients got a little sprinkle of calcium throughout their whole tendon, and I would imagine that's what they're looking for. But it is. The patient needs to have a conversation with the therapist as to, you know, what they really think their chances of getting a benefit out of it is, because you don't want to be stirring them up. Go on.
I was going to change from PRP.
Go on.
Have you used that at all? Do you use that?
So I do use PRP. So PRP is where we take plasma and spin it down and then re-inject it back into the tendon. So my favourite PRP person is someone who's got an intra-substance tendon tear. And so they're very rare and they're often young. And, you know, sometimes they've got that sort of, you know, you're looking at it and you sort of think, gee, it's almost like the articular side is more torn than the bursal side. So it's an unusual tendon pattern. And so it's an isolated tendon, which is a contained defect. Sure. So if I see that, I'm like, oh, you know, if I had this, I would probably go and get PRP for this. And I have a conversation about it because it's not funded by work cover. It's no local anaesthetic. So the patient has to be motivated and want the procedure. So there's absolutely no point doing it if they've got any misgivings about it, because they'll just take a piece of paper and throw it away. So it's about, you know, do you think this is right for you? And, you know, are you interested? And I encourage them to, you know, Google it, research it. The trick with PRP is that the science behind it is very challenging because it just took off and there's no standardization of the actual process. Go on.
The variability of product for PRP is huge because it depends on the centrifuge spin cycle, timing, speed. You can get leukocyte-rich PRP, which is great for tendinopathy, and leukocyte-poor, which is appropriate for OA.
Dependent on.
But you do not.
No, how much you spin it?
It's all about the spin speed and the spin length of time. So for OA, you do not want to be putting leukocyte-rich in there. You'll stir up inflammation. And for tendinopathy, you don't want to be putting leukocyte-poor because it'll do nothing. So
you want the leukocytes to kind of go and do their work.
So that's where you're going to find the right system.
What was that?
I had something to do for OA with PRP.
It's got more evidence in the knee than it has anywhere else. They're trying to do the evidence for the hip. They haven't got doing evidence for the shoulder for the OA. But tendinopathy is what the sports physicians will be injecting PRP, but it's got to be leukocyte-rich because otherwise it will do nothing.
So it depends on where you're putting it. So what I'm describing is you would put it in that one focus. But yes, I do refer for osteoarthritis. We just put it, I try and encourage them to put it in the glenohumeral joint for osteoarthritis rather than just sneaking it in the bursa on the top because the bursa is not connected to the glenohumeral joint so that it won't get delivered. The other one is Synvisc or Durolane, which is the injectable hyaluronic acid. I do use them and I'm happy to administer it, but dealer's choice whether or not it works.
Is crap.
The evidence, 24 hours later, it's hard to demonstrate that the product is still in the joint.
Anecdotal benefit for 6 months in the knee.
Really? Is that the study?
Yeah, that's all the studies in terms of the promotional stuff behind it.
Yeah.
And they're trying to get similar evidence, but it's all anecdotal and there's nothing to prove it, because theoretically you stick that stuff into the joint, it's theoretically going to aid the glucose and mini glycans in holding water or synovial fluid.
Yeah.
But there's nothing to say that that will stay in the joint longer than a couple of weeks. So how do they get
6 months of
how do they get 6 months of relief?
Yeah.
Well, that's why no insurance company in Australia will pay for it.
So I don't listened to an interesting talk, because I'm always listening about shots the other day from a orthopedics specialist, and he was saying that you could actually just they've gone away from it for no particular reason, use nicotine patches on the tendon. Yeah, that idea of, and he said they're probably easier and safer and cheaper.
We did it a lot for tennis elbow.
Yeah, he uses on the shoulder. I've never heard of that.
It depends. I mean, I would imagine it depends on the size of their deltoid. I mean, if you're looking at some big guy, then the penetration of the GTN patch wouldn't be too far.
Yeah.
You just have to warn them about headaches. Yeah. And they can also cut the patch quite small. Like you don't have to give them the great big mega dose. You can just cut it into smaller pieces and then use quarter patches.
Because
it's an old fashioned angina medication. So it was for people with, back in the days when people had cardiac stenosis and we couldn't treat it before stents, you just try and break open the blood vessel, try to force it open with chemical treatment. And so basically what it does is increases the blood flow where you put the patch. So that's the theory behind it.
Yeah, I think so. It's gone back to using those because there's
why not
little side effects and not much to lose.
Why not? Yeah, if you can get it to heal. There you go.
Yeah.
That was a bit wide.
Awesome. Yeah, no, I love it.
Christian, this is why they didn't want me to come.
You haven't said that.
I did not.
No. So I mean, we'll move on to glenohumeral joint instability because we've basically spoken about that sort of stuff. So
25 minutes on the cup. So
yeah.
Let's go with instability.
So traumatic, obviously.
Yes.
Congenital and atraumatic instability. You've got the ones that obviously the traumatic dislocation. Yes. You would surgically intervene, reduce it as soon as possible, basically, in a hospital setting?
Now, the longer you leave it out, the increased risk of axillary nerve palsy. So they do actually, their deltoids, you can check them later, and their EMGs aren't great. So yes, it is a surgical emergency to get it reduced. It's not just a shoulder dislocation. It's something you really want to actually get it reduced. And there's lots of different ways to reduce it, but I had a colleague who used to reduce it on the field, and he said you lie them on a bench with their arm hanging over the bench, and if you can, coax them into relaxing, he reckons that they can often get back into place.
Is it external rotation and traction? Is that what it is?
Yeah, the Hippocratic method. But so the issue you have is you don't actually know what's happened. Could it be a labral tear? Could it be a glenoid fracture? Could it be a proximal humerus fracture? You really don't know. Yeah. So it's nice and to look at them, and they'll have quite a prominent humeral head, and their arms quite they can't move it. That's always a good chance that that's what you're dealing with. But I mean, I guess my thought is traction and relaxation. You might just get it to kind of just pull back. All you need to do is lift it off where it's tucked in front of the glenoid. All you need to do is lift it off a centimetre, and it'll want to go back. But it's also a matter of listening. If you're on the field, it's also a matter of listening for it. Did it go back and fall straight back out again? That sort of stability. Like you think, oh, did I not reduce it, or did it go in and fall out? That's a different finding, because then you've just got no glenoid face. Like it's going to keep falling out. So that's an important thing to document.
So you mentioned the nerve compression. Is it possible to compress an artery as well, or is that?
Haven't seen it. Okay. Haven't seen it. More common in like clavicle fractures and things like that. But I haven't seen it because so what's happening is it comes out the front and it gets traction on the axillary nerve from posteriorly. So it's not like it's pushing on the brachial plexus, it's pulling on the axillary nerve. That's the problem.
Sure.
But are you going to talk about atraumatic?
Atraumatic, yeah. So generally those sort of well, it can be like you see it mainly in those like slender girls, those multi-directional instabilities at a young, hypermobility at a young age. And you also get those sort of like overusey, what's it called, the acquired instability due to overuse syndrome. So typically with those, I mean, both of those, I found that the guidelines that you would try and consider conservative first, and then in sort of like 3 to 6 months, if they weren't happy with their progress or they just recurrently slipped out or they had serious like problems with apprehension and things like that. I guess once the younger children and like those adolescents grow up a bit, the open states stiffen up a bit more as well, get a bit more musculature on them as well. But generally you sort of, as you're assessing them, you're doing a shift test, the apprehension test, and it's quite like sensitive and specific, like that shift test. They can pop,
I strongly agree with that. Specific.
And the apprehension test as well. And the relocation test is quite a good test as well, especially for those anterior instabilities.
Correct.
Yeah,
I agree.
Yeah,
but I think it's hard in GP land because what we're talking about is we just take the human head and we just slide it backwards and forwards. You think, how can you possibly do that? You know, particularly if they're a bit of a bigger guy. But as you say, they're often young and they're slim and they're less muscular. So because I'm only little, I have to get them to relax, and you can kind of feel them like this, and so I get them to, and you've kind of got to catch them a bit by surprise because they've got to be really relaxed. And sometimes I can get them to go in and out, and then that's it. They don't like the feeling so much, but they just won't let. It's
not fun.
They're
definitely. They're like kind of freak out a little bit, like jump at it.
Yeah, they get a bit anxious, don't they?
Well, it's literally like shifting the humeral head, translating forward.
You can actually move it around. It is sufficiently mobile. So the reason why I say that is because then they go, that's it. That's my problem. You know, then they know, and you've communicated with them that you understand what we're working
Exactly. Exactly.
And so what do you do with them?
So you start them off with like a pretty basic closed chain exercise. So you're trying to, and like basically trying to get, closed chain, like hands on the floor, hands on the wall, those sort of things. So open chain would be the hand in the air, closed chain would be hand on a surface, basically on a wall.
So just holding it there.
Yeah, so you could do push-ups on the wall or push-ups on a bench, for example, but then you can start to sort of add more weight to it, like change them to their knees or start to get them to actively have a close change. But you'd probably start with more proprioceptive stuff as well, because they're quite scared to move their shoulder initially because it keeps feeling like it's about to pop out basically. So you can just start them on their back and just like get them to sort of just feel for their like the right joint position, because they can generally get it in that position with some proprioceptive exercises. Then start them off with some closed chain stuff as well. Then progress to a bit harder closed chain stuff, and then open chain as well.
Are we talking any instability or multi-directional?
Multi-directional.
We're talking about this sort of atraumatic. Yeah. So we're not talking about the proper traumatic one, which we had before.
So
did you have a...
No, I was thinking, was this the general approach for a traumatic? Or is it
more multi-directional?
So it sounds like you start them pretty gentle.
Start them pretty gentle. Well, it depends obviously on the severity and the irritability, but depending on if they've had a traumatic event or it's I'm sorry, not
so if we're doing a
traumatic event, basically you're just trying to get them on the right track with their rehab. Like a lot of the time it's just like their movements can be painful, so it depends on their irritability and severity.
So you sort of take them right back to the beginning and start with closed chains, start with proprioception.
Definitely. I mean, if they're comfortable with it, we can move on straight away. But you assess where they're at based on their level of pain.
I think the ones we see too, because we're seeing the high level unstable female athletes. So we have the baseball players, netball type, and cheerleaders. So they're super fit, but they're super anxious at the same time because
they've got so much riding on it.
Yeah, they do. And they're super unstable. So they're great to work with, but you really, it's interesting trying to, you have to pick that level that will match what they're trying to do all the time.
You mean you can't wind them back too far or they won't come with you. You've got to meet them where they are.
Yeah. And you have to be able to get, like my Thai pants girl, she was she just went, I've got to do cartwheels. And I said, you won't be able to. And I went to watch her at the time, and she just did it without her arms. Right in front of me, she's not away. So, you know, it's not really level of working with these girls. I mean, as though she's double reps.
Yeah.
So she could lift her arm because it's so sore when they start, and they're so devastated because they really don't think they'll be able to get back there. And then you work them through, and they're great to work with.
Yeah, they are. They're motivated.
And they learn to live with their instability because they won't change till they reach maturity. So they have to learn to. They have to be doing the stuff we get them doing, like one are doing handstand push-ups and things like that.
Yeah, to get their strength.
Yeah.
Do you have a question?
Yeah.
Sorry, have you got a question?
No, I'm not just.
Yeah.
Closed versus open chain, do you mean in terms of planes? So closed is just in one plane, or what's the open?
No,
It means connected. Yeah,
connected to the ground.
So yeah, connected to a surface basically. So closed.
It's not like isometric and
Okay.
yeah.
As opposed to lifting away,
Yeah.
which is open chain.
Yeah.
Yeah, I think
You're pushing against a wall or on the floor or something like that.
So you're stabilizing the hand opposed to opposed to moving the hand.
Yeah.
So you move the body on the hand opposed to moving the hand on the body.
Yeah. And the reason we do that is proprioception, which is joint sense, is really bad in people with hypermobility because the joint moves too much, so they don't get a lot of feedback. So if you do it open chain, they're likely to move into places that they shouldn't be. But if you give them that proprioceptive feedback through impression, then you're much safer and they get much better control and they can do a lot more. Yeah. So if you throw a weight, 5 kilo weight on the end of their arm, they'll freak out, but they can carry the body weight. So that's fine.
Yeah.
Yeah, so that's why.
so they can do a push-up, but they can't lift.
They do a handstand. Like, yeah,
As long as they're touching something. As long as they're
if
stable.
they go to throw a softball, it comes out.
Yeah.
So,
Yeah.
Yeah.
So we train them with resistance and shut them down, and then train them into all out of whatever. That's good.
But it also gives them proximal control, doesn't it?
Yeah.
And by starting closed chain, they get the idea of proximal control on the girdle.
So
Long discussion on that, but it's probably about this. Did you hear my?
so yeah, calf strength, shoulder girdle strength, and proprioception are the main things you're looking for in those, and you're trying to address those active structures because obviously the active structures aren't doing their job as well as they should.
Yes.
Yeah. So should we?
What have you got next?
Yeah, should we move on? Biceps related pain?
Oh yeah.
Yeah.
Yep, good. Yeah, love to. Love to advice. Go on.
So obviously we get those sort of acute heel back, like dropping an object, peeling back on the labrum, those sort of behind the body movements. Those are the main things that I tend to see. It's in slat lesions as well. Yeah.
Do you know what a slat lesion is?
Basically, it's like
Okay.
Definitely.
Do you know what a slat lesion is?
Oh, yeah, when you're going to get like a snap turn, you've got to do the repair.
Yeah, it's not the right answer. Did you hear that? Slap tear needs a repair. Well trained.
Nails are between.
That's all of it.
You tend to get those popping and clicking sounds a little bit there.
Yes.
Yeah.
You describe.
Yeah. The ones I've seen tend to have that sort of like. I think Kelly.
Is it Kelly?
Yeah.
Right, his name.
Oh yeah, sorry.
No, that's right. No, they can describe it.
Yeah.
So the little piece in there moves it around a little bit against the front of the gleno, but it doesn't actually dislocate it. It flicks past it and they can feel it.
Yeah.
And sometimes that builds into irritation. And yes, I do love to repair them. I think that's a fabulous operation. But you can try non-surgical treatment.
Yeah, definitely. What I tend to say is what I tend to tell them is 3 to 6 months of conservative before
What you need.
Yeah. Before if they're unhappy with the results after that, then a surgical refer to a specialist.
Yeah. That's good.
Yeah,
but that is also different. So the slat tear, what we're talking about is the labrum. It's the same. It's the calamari ring that holds the ball into the socket, and the O-ring tears. So the calamari as an O-ring. And so when you dislocate the shoulder, it's the anterior and inferior corner. So that's why they come out the front. But the slat tear is actually the superior part of it. So it's not quite such a critically important structure, which is why you can definitely get away with non-surgical treatment. But the biceps tendon inserts on it, which is why he's talking about it in relation to the biceps tendon. The biceps tendon inserts onto the top of the labrum. So go on.
Yeah, I find that like testing them objectively, if you do them in standing, they can sort of have a. If you test them, the resisted biceps in standing, they can have a bit of an anterior translation and sort of cramp down. But if you do it in supine, it sits them back into a better position, and you can really isolate. Yeah, you know, and you can feel for it a bit better as well, the biceps tendon, when you're trying to assess for it. What do you find the radiology wise, like what's the gold standard there?
So one of the radiologists said that an MRI scan always shows biceps tendonitis. So he says sometimes he just, you know, doesn't think it's worth reporting because it's always there, which I think is a really interesting observation. It's a bit like bursitis. If it's always inflamed, what's going on? You know, like by the time they present, they've always got an inflamed biceps tendon. So what I mean by that is the sheath. If you look at the MRI scan, you'll see that the sheath is much bigger than it should naturally be. Why is that? You know, depends, you know, other clinical signs and symptoms, but it's much more frequent probably than we expect.
Okay, sure. Conservatively 3 to 6 months of non-operative management and improving shoulder function.
How do you test for biceps tendonitis?
Biceps tendonitis?
Yeah.
Well, you test resisted stretch.
Yeah,
resisted stretch, like that's in an objective.
Down here.
There's no. Hey.
I always put it up here. No.
The difference is differentiating in short and long head biceps. So so the old bowling test is what we use.
Yeah.
Okay.
So we tell people pretend they're bowling a long ball and they come through and you resist it. And normally they got the long head.
Yeah, there's no gold standard though. So like there's nothing that will completely rule it in or rule it out.
Yeah.
So,
because as you and I discussed, if you have any subscat signs, they also will become positive then.
Yes.
So again, we're clustering subjective and objective signs.
So you're sort of talking about, before you were talking about infraspinatus and supraspinatus being clustered together at the back.
Yeah.
And now it's also hard to distinguish between biceps and subscat at the front.
Bring them back here and they've got a subscat problem. You're going to pick it up.
Yes.
And then you're going to pick up heel and resistance. So.
Yes.
So the clustering.
Yeah, 100%.
I agree.
They have similar functions as well.
So what we're trying to say is, you know, there's 1,000 tests that you could potentially sit down and memorize. And we're trying to say, don't do that because the tests aren't. And I've seen that there's that fantastic American Journal of Sports Science or something that did every test, you know, specificity and sensitivity, and there's like 100 different shoulder tests. So pick something that you like and that you've got and that you understand, and just use that consistently, because then you get a better feel for the test in your hands. Do you see what I mean? So you do the test and they're like, nothing. You're like, okay. And then you do the test on someone else and they light up like a Christmas tree. You just get a bit of a feel of how the test works in your hands, which I think is much more important than the actual test that we choose.
Also to Physio, we can do a test for you. Sometimes it's to ask that's what we do all day, send it to us.
Yeah.
I know the athletic population you've got.
Anyway,
All 3 to 6 months mark, because if they're highly active, if it's a slap turn you go for, would you be thinking more so?
Well, of course, everyone needs an operation. So we're trying to give you a balanced perspective here. So he's like 3 to 6 months, right? So that's the purpose of the talks, is to try and show you that, you know, we've got a very different perspective. But I think we see a different population group. I see the acute work come up. They can't afford to be, you know, thinking about whether or not they want an operation, because they're under so much time pressure. And so that's 50% of my workload. So it's a different population. They've got a very different mindset before they even come in. If it was mine, maybe, you know, I'd be very happy to do 6 months worth, because I need to know that I've done everything I could possibly do before I would consider surgical intervention. But you've got the feel for the patient. You know, you look at the patient and you're thinking, there's no way they're going to, or they say to you, physio doesn't work. You know, I had it on my knee and it doesn't work. And, you know, that's a long conversation I'm sure you know, that's a long conversation.
I mean, I guess the question is for us, when we do imaging as well and scans and things like that, because we initially think maybe refer to the physio without doing imaging, because that's then committing to a certain.
Correct. That's the concern.
So what I said, he talks about shoulders. X-ray. to exclude something that's scary.
Yeah.
You've got
You know,
to exclude
if we get a clear X-ray, we are good to go. We can call everything else, and if we don't, we'll send them back to GPs to go on to all those if we think we can't miss it.
Yeah.
But I love things turning up in an X-ray just so I've excluded.
Because it also shows you the calcification.
Exactly.
Calcifications,
fractures. Yeah, they actually got osteoarthritis, and you can't push them into moving too fast.
Yeah.
So an X-ray has a, it's not so popular as it used to be, but I strongly agree with you there. I love an X-ray.
Sure.
Just
always look at myself.
You know what really say to a patient? Well, it's none of these things we have to worry about. It's going to be probably these things. Give it a go. If we can pick up, there's probably a slap lesion in there.
Yeah.
And so
you should be able to detect a slap too.
This is what I think you have. This is how I'm going to approach it. If it doesn't get better, then we've got this pathway as well. But if you had a slap repair, it's only 18 months to be happy again. So just get that.
Because you've got to go backwards before we come forward.
Yeah.
We make them too tight. And that's very intentional. A lot of orthopedic procedures are just, so the patient tears it, and then we over tension it, and then they relax it back to normal. So and that's a long process. And some people are quicker than others, of course, but they can get very tight.
And in the surgical world, there's a golden rule of never do a minor slap repair over a certain age because they'll never get their range of motion.
Range of motion, yeah. Well, I just tend to warn them because if they're if they're talking instability, and when I see them, I mean, men much more commonly come in with rotator cuff tear. So if I hear instability, then I say, look, I can do this operation, but you might lose your external rotation. And they're like, no, it feels too unstable. That's the complication. They say, I'd rather have stability and lose external rotation. So I even do that, even with anterior lateral tears. I say, it is possible that because I'm not dealing with athletes, I'm dealing with people who want to be able to throw a hammer, want to be able to work, and want to see out their career. So they don't actually, they can modify their life to cope with a bit of loss of external rotation. And look, if they get it in 5 years' time, that's okay, because they've had that use in the interim. So I'm trying to make them functional for their specific job too. And often, if it's this, they can cope with that, a bit of external rotation for a while, so they get back to work earlier. Although it's the longer recovery time, I can get them back to functioning, which is all they want to bring. Thank you. No.
The other ones that I always warn they're going to lose external rotation, and they will just have to suck it up. Are the hypermobile ones?
Yeah,
because if they spend the rest of their life working out how they can do 300 degrees in this one, and now can only do normal in this one. So you have to say to them, we don't want you to be hypermobile. That's why we're doing the freaking operation. So don't aim for that, and don't stretch the hell out of it to try and get there.
Yes.
And don't let your gym coach do that and stand on your arm to get the range out of it. Because then I'm going to have some fun.
We're gonna have some fun. Yes, it's the same with the patellofemoral joint. We try and make it like really stable, and then they just go crazy trying to stretch it straight back up again. So you've got to have that conversation before you start. Can you cope with the fact that it's going to feel abnormal forever, because it's not actually, if we're taking it back to normal, we're not taking it back to normal. So it's important that they understand that it feels tight. Because otherwise they'll fight it, and they'll just fight it forever until they loosen it back up again. So
that's okay. Should we move on? Posterior shoulder stiffness?
Yeah, come on.
So internal rotation deficit, glenohumeral internal rotation deficit, are very common in throwers. The theory is that sort of the rotator cuff can't slow down the deceleration of the arm during cockings, overhead sports, so serving, throwing, swimming even, a bit more unlikely, but yeah, mainly throwing sports. And that causes sort of micro tears to the back of the musculature and the capsule, and basically causes an internal rotation deficit. So hand behind the back, very hard, especially passively. It's very restricted compared to the other side on their dominant hand. So generally what we do from a conservative point of view is try and stretch out the restriction. Now, we're probably not stretching the capsule because it's very fibrous, very tough. we're probably getting the muscular contractures like to move a little bit. So it has been shown that like the sleeper stretch and sort of cross-body adduction stretch has been shown to improve range of motion over the course of about 6 weeks. So the theory though, on the other hand, so that deceleration, that theory is it's slightly weak as well. So you should probably train the cuff as well. So in this position to be able to slow down the humeral head as it sort of cocks through. So that is generally what we would do from a conservative standpoint for sort of shoulder stiffness. I don't think there is is there a surgical option for that?
You can release the posterior capsule.
Does that work well?
Look, to be honest, whenever I see any posterior labral issues, it's a heart sink moment, particularly when I'm operating and you look at the posterior labrum, you look at it and it's scuffed, and you look at that posterior capsule and it just looks hard and leathery. I just think, this shoulder, and that's in an osteoarthritic context. That's not in your athlete context. That's in a early, first stage of osteoarthritis to me is scuffing of that and flattening of that posterior labrum. So that's the first thing I ever see. Sometimes I see a little bit of glenohumeral cartilage loss, but that posterior labrum, once I see that, I think this is going to be a long rehab. So as far as what you see arthroscopically, posterior labrum just looks like everywhere else. It's really hard to notice that subtle what you're describing. But we don't spend a lot of time inside their shoulders. This is not a population to spend a lot of time arthroscopically.
Yeah. Sure.
And so you can do, capsular releases on anyone, but preference is always to do it on those frozen shoulders because you really get it. When you put the wand in, you can really feel it. You can feel it punch through. Whereas normally the capsule should just be like so fragile and soft. It should be a really delicate structure. Yeah. So presumably in these guys, it probably doesn't need to get much tougher than natural.
Sure.
Before they're amenable to physio.
Sure. Okay, fantastic. So finally, last point. So scapular pathology, mainly AC joint and SC joint, sort of sprain, fracture, dislocation. There is like an old scapular dyskinesis sort of diagnosis, but that is under some scrutiny as well. So mainly going to talk about AC joint, SC joint, and sprains, fractures, and dislocation. So lots of surgical sort of could be. What do you
think about AC joint reconstructions?
Well, it depends on the patient. Depends on the patient for sure.
Yeah, but what do you think about the results of them?
I haven't seen too many actually. No. No.
Anna's nodding. Peter. Yeah, Peter, you're an implant expert, so.
Well, yeah, I don't know a lot about the implants, but I've never seen post-op.
Post-op?
No.
Have you seen the post-op? What do you think?
I think you have to be a committed patient and have a good reason to do it. It's really so
patient good reason.
Yeah, because I think it's not the AC joint as far as its roles in the shoulder. It can have a fairly big deficit without affecting the shoulder biomechanics. So you have to have that. They usually have to be a physical person using it because if, like I said, they're a typist and that the AC won't normally cause some problems. They have to be willing that it's pretty tough surgery and it will affect the shoulder. So they'll actually get worse before they get better just because of the post-op.
How tight it is.
Yeah, and how tight it is. I've seen it work. I've seen probably only 15 of them in my career.
Yeah.
And they've all, and I would consider those, they were all successful actually.
Yeah.
Just because they picked the right patient.
Yes.
And
they
were really had these horrible ACs that were really impeding.
Quite displaced.
Yeah, they had to do often they had to take out big spurs and stuff that were impeding to actually put them together.
Get it to align back up.
Yeah, so that surgery alone, that was quite a bit. That's why they had to bind them back down because they had to take off so much shitty bone.
Yes.
So there have often been those sort of motorbike accidents.
Yes.
Matched AC apart and they've managed to conservatively in over years. It's just got to the point that they're not functioning. So I don't have any problem with the surgery. You just right patient and why you're bothering to do it.
Yeah, I think that's always the way, isn't it? So what we're talking about is the AC joint can get a dislocation, and there's a huge range of microscopic dislocation which you're sort of looking at it going, I can't really see anything, and then it can be quite displaced, where almost like the scapula kind of falls off the clavicle. You can imagine that. So people think their clavicle is sticking up, but actually the scapula is rolled off. So there's the whole thing's quite unstable in that group. And so you can actually do a procedure whereby you bring the clavicle back to the coracoid, which is part of the scapula where it's supposed to be attached. And the problem we have at the moment is there's no, well, I'm sure Peter's probably got an opinion, but the technology is in a bit of a state of flux. So you can use a suture graft, so you can just put a stitch. It's a highly sophisticated piece of tape, really. Or you can use graft, or you can do a combination of both. And the fact that there's 3 different options always makes me nervous, because it suggests that no one's happy with any of their options. And I hate harvesting somewhere else, even the palmar, as long as I hate harvesting any other tendon, hamstring, to try and reconstruct another part of their body. I just feel that you really have to have a good think about it. So my preference is to use a tape, and accept that 1 in 100 might fail, and I've got to go back and take a hamstring. So I try and rehab them really slowly, because I know, because as you can hear, you've got to read the operation report to know what's in there. Because you don't know if they've got allograft. That's the third option. So sometimes they've used an allograft, and that could work for 3 months, and then suddenly you've got nothing. So you've got to kind of see the report to know how fast to rehab them.
Sure.
But I use tape and rehab slowly. But if I probably used some sort of living graft, then you might be able to rehab them a bit faster.
And the question while we discuss it is the outcomes for the non-operatively are pretty good.
Are excellent.
So they're not a really big reason to do them, because 90% of them, even though don't go to the farm. So I have actually had a few go back and have it done cosmetically, because it bothered them.
They don't like the bump
because they're skinny and gorgeous, and they hate having their silk shirt show through. It seems to me a little bit of a
You can just clear it off though.
Different Sydney. But yeah, so the outcomes really for most patients will say, look, that you'll be fine. You end up with a month there, it won't cause you any long-term problems. So it's probably not worth having an operation for, unless they're unstable.
So the other side to that is, we're always happy to talk to the patient and walk them through it. They come in.
They can always go back.
Yeah, and it's like the clavicle fracture. The patient comes in and they're like, what? They can see it. They look in the mirror and don't like the look of it. And so, we always just sit down and talk to them. And that's what we do.
Yeah.
Explain the risks. Go on.
So basically what you said, starting on slow rehab, isometrics, when able, and then progressing with range of motion when the doctor said, basically.
But if you're treating them conservatively, isometrics,
and then build up cuff strength, maintain cuff strength if you can, but you want to the AC joint has to heal on its own, basically. So you can use tape to stabilize it, and that makes it feel a bit better. And you can use some passive therapies to help with some of the muscular guarding and things like that. Good. But generally, you want to slowly build them up with isometrics. Yes, horizontal adduction is going to be painful every time, and you can pretty much just touch them on the AC joint and we'll send them to the roof. It's
subcutaneous joint, so you should be able to identify. That's a good point.
So but unless obviously it's traumatic and there's a bony fragment like poking out or something.
So you can get a very lateral clavicle fracture, which is basically an AC joint dislocation in someone whose bones are weaker than their ACJ ligaments. So that's a complex problem.
But as Anne said, they usually do really well. Like conservatively.
Yes.
So
I would strongly agree with that.
Yeah, cool. So basically just key takeaways for patients, like in general, like keeping healthy and keep your shoulder healthy. Who would have thought? Biopsychosocial model. Addressing their psyche and their social stigma. Social scenario. It all comes into it, especially with more chronic, obviously, but it all comes into it. So being realistic with the prognosis. So anywhere from 6 to 12 weeks for a rotator cuff tendon, or anywhere up to 2+ years for a frozen shoulder, or something along those lines. making sure you're telling the patient that pain doesn't equal tissue damage. Like,
Yes.
so analyze the traffic light system. Like if it's like sort of a 0 to 3, like out of 10 for most cases, you can sort of push through it. Anything like a little bit like 4 to 6 is just like, if it, steady on, and then stop if it's anything more than that. It depends on a case to case basis, obviously, but those are just some key points to take away. And I'm just throwing in like Jill Cook's tendon continuum model as well. Just sort of
explain that to a GP.
Yeah, so like a normal tendon, so you can have two types of sort of tendon issues. You can have a reactive tendinopathy or a degenerative tendinopathy. So the reactive tendinopathy is either overdone or underdone, basically. So it's either it's exceeded its tolerance or it's dropped below its tolerance, the activity put on it or the stress put on it. And that can basically, it all feeds into this sort of tendon model that you just need to get the right balancing act. You need to get it stronger, but not aggravate it. But you can push into a little bit of discomfort. Does that sort of make sense? Yeah.
Tendinosis versus tendinitis.
Yeah.
Yes.
Make that distinction.
Yeah. So basically the tendinopathy is just a broad umbrella term to sort of fit both of those categories into it.
What do you do about those patients who have kind of autoimmune induced tendinitis? Because they're going to have recurrent symptoms. Like, what's the physio kind of
solution for those that rheumatoid arthritic type of generalized arthropathy sort of people?
So generally, do you want to help me with this one?
So when you're looking at systemic things, the shoulder, so there's not only autoimmune, like thyroid's and massive thing, diabetes, autoimmune. The understanding for patients is to understand that strength is good. So they don't have, you can have pretty crap hands and still have strong shoulders. So there's no advantage to having the whole system being terrible. It's understanding what are your triggers. So if you're flaring, then you need to manage your program to accommodate that flare. And it's not that hard for patients to get that, what that looks like with the traffic lights, basically. So if you're already at 6 out of 10 because you're having a flare, then don't exercise there. Come back where you're comfortable and green. So that may be, some of my patients may be walking in the pool. They're still exercising, and then we have little things like they might get a kickboard, or they put noodle around their waist to have resistance, or there's a billion other things we can use. So they'll do that when they're bad, and then as they come out of their flare, they then match their exercise and strength with it, so they don't continually lose everything. And so it's about managing, and the same with my thyroid's good one. If their thyroid goes off, they will get really uncomfortable, and the exercise tolerance will drop right off, and their tendons are menopausal. So my tendons hurt all the time. But I'm going to use that every day. So there's constant things systemic that will interfere. It's understanding that doesn't mean stop, it means manage. So that's the message I say to all my patients. Okay, your hands are terrible. Is your shoulder pretty good still? Yeah, we'll get in the pool and do rotation stuff with your shoulder. Your hands may not in the pool, but you're in the pool
because they just get osteoporotic.
So
quickly. And then they fall over. And we know suppressant drugs affect the tendon structure. So we need those tendons to have enough resistance in them that they don't destruct themselves, which tendons do really quickly. So that's my message to people. Understand where your tolerances are and maybe move your tolerances to you.
So it's the same exercises, it's just graded according to where they are. We have a very good physio, so I tend to, those guys send them to the pool with her once or twice to learn a pool program and then have a land-based program. So if they're having a flare, to get them on board more, because they can do more and maintain more. Once they're not flaring, get out of the water because they need a movement. So it's about trying to give them 2 options all the time so they continue to do something. And that's usually what we do. And to recognise when they get the hard drugs for the hard suppressant drugs, they're going to have to be gentle with their tendons. There's this huge tendon rupture problem, rotator cuff failure when you're on those drugs. So in cancer patients, we need to be aware they need to build muscle, but while they're on the chemo, those drugs affect tendons. So we need to be a little bit careful.
It's definitely don't stop. I think that's what you said right at the beginning about the escalating and the fear and the terminology. Sure. Just the theory of rest came from treating infected joints. So that came from the 1800s, late 1800s. If you rest a joint, the infection improves, and the these consequences of the septic arthritis are less if you rest the joint. So that's where the theory came from. And so it's just evolved into a treatment for arthritis, resting the joint because it's arthritic. But there really isn't very much evidence for
worse than it. It's actually worse. I think what we probably for GP, if we want to take away from what we're talking about, is our shoulders sort of go down this line of under 35 and over 35. So under 35, there's so much potential. There's much more likely one injury, one problem, one thing to deal with. Over 35, you're probably going to start clustering rotator cuff a bit. So you're probably less likely to rush into saying, we should repair this, because even with, I mean, if you've got a tear of less than a centimetre in your supraspinatus tear, all the research shows it won't accelerate any faster whether you weight it up or not. So you're not going to make that tear worse if you're over 35. So you can go and lift 100 weights, it won't make that accelerate any worse than if you just left it nothing. So there's no reason when you're over 35 to start pampering. If you're under 35 and you're tearing your tendon, we probably need to be a little bit more careful with that, because that's a little unusual. So we need to try and rehab you, but also watch you. So that's where we sort of get these patients. So patients coming in with partial tears who are my age, 50, I'm like, yeah, MRI of my shoulder, you'll see at least 3 and 2. You join a club. Yeah. So that's, yeah, and that's what I say to them, like, you MRI 100 healthy 50-year-old shoulders, 50% of them will have a 50% tear in their supraspinatus. So that's sort of say to patients, if you MRI 100 20-year-olds, you would probably see 20% of them, if they're athletic, will have a 20% tear. Now that's, that's watching, but 50% tear, that's, that's a big tear, but you're still getting lift weight, run around, swim, do everything you should do, because you're not going to make it worse.
So disc bulges.
Yes, disc bulges, so good.
35 is my little magic number as they walk to the door.
It's all over at 35.
It just makes me think differently. Like when I have a 30-year-old coming in with a sore shoulder, he's like,
so my flags go up. I'm like, hold on, what are you doing here?
What are you doing and what has happened? Like,
yeah, you have to be very clear about what happened to you. Even for a couple of times, why are you here? What happened? And sometimes they can't always tell you what went wrong, but I bring them back. What happened? What happened? Do you remember what happened? How did this happen? Because there should be an injury. Well, we're over time.
Yeah.
So we're going to have to stop.
Yeah, we were done anyway. We were done anyway. That was perfect. Beautiful. No way. Thanks,
yeah. It's stuff on everything.
It's stuff on everything.